Well, greetings to everyone. Today we come together from different corners of the globe. Firstly, I want to thank you for joining us, no matter the hour in your part of the world. I wish you all an inspiring and productive symposium. My name is Görkem Yararbaş. It's my honor to welcome you to the Focus on Addiction Care Symposium. We gather here today to advance our understanding and improve our practices in addiction care. This field affects millions of lives across the globe. It's a field where science, empathy, and innovation intersect, challenging us to constantly seek better ways to support those grappling with addiction. Over the next few hours, we will explore a range of topics. We will hear from the leading experts who are bringing new insights and perspectives. Their presentations are not just a showcase of knowledge, but an invitation for dialogue, collaboration, and growth. The landscape of addiction care is complex. It is influenced by cultural, social, and individual factors. In recent years, we have seen significant shifts in types of addictions we encounter, as well as in methodologies we employ to address them. These changes present both opportunities for advancement and hurdles to overcome. Before we proceed, I want to express my special thanks to everyone involved in organizing this event. It's their hard work and dedication that has made this gathering possible. As we move forward with the sessions, I encourage each of you to engage actively, ask questions, share your experiences, and network with your peers. The connections you make here can lead to collaborations that extend far beyond the confines of this symposium. Let's use this time together to reflect, to learn, to inspire together. Then we can push the boundaries of what's possible in addiction care and make meaningful impact in the lives of those we serve. Thank you for being here, and I wish you all a productive day. Thank you.
Thank you so much, dear Görkem, for this great opening speech. Thanks so much. And okay, good evening, good morning, and good afternoon, ladies and gentlemen. Welcome to the Focus on Addiction Care, New Approaches, Advanced and Challenge International Symposium event today. My name is İnci Derya Yücel. I work at Ege University Institute on Drug Abuse, Toxicology, and Pharmaceutical Science. On behalf of my organization, Ege University Institute on Drug Abuse, Toxicology, and Pharmaceutical Science, Department of Drug Abuse, I'm delighted to welcome each and every one of you to this great symposium. Greetings to our distinguished guests, esteemed keynote guests, and host speakers, and all the participants joining us today. So today we gather to explore, learn, and engage in meaningful discussions on addiction, but especially intervention models, new international models according to our experiences in a scientific way. I hope this symposium will give all of us a platform and opportunity to share expertise, foster collaboration, and advance our collective understanding of behavioral addiction, tobacco, substance, alcohol addiction problems, and of course, solutions in the field. Throughout the day, I encourage you to actively participate in discussions, especially Q&A, question and answer sessions, network with fellow attendees, and make the most of this collaborative environment as online. Once again, welcome to Focus on Addiction Care Symposium. I hope you have a rewarding and enriching experience at this event. So first of all, I would like to introduce our first keynote speaker, Professor Dr. Michael Schaub. I have the honor of introducing a distinguished and our first keynote speaker, Professor Schaub from University of Zurich the Swiss Research Institute for Public Health and Addiction from Switzerland. Professor Schaap is a trained psychotherapist with a strong clinical and scientific background, as well as a public health expert in the area of substance use disorders and also behavioral addictions. He will be sharing his expertise with us with his presentation titled Digital Interventions for the Treatment of Behavioral Addictions. Okay, so the stage is now yours, dear Schaap, please.
Thank you, Inchi. Thank you, Görkem. Can you hear me loud and clearly?
Yes, I can hear you. And
okay, perfect.
you can see.
Well, thank you for the kind introduction. And so, yes, my task for today, and sorry, I'm a bit in a small room today because there is an ongoing launch of a study regarding cannabis control trial in Switzerland. That's why I have to be a bit careful inside here. Yes, the title is Digital Interventions for the Treatment of Behavioral Addictions. So for some of you probably are more interested more in the digital part, others probably more in the behavioral addictions part. So I will have both topics a bit on the screen today, and I will also focus a bit more on some more scientific purposes and goals, and on the other hand, also some more practical things. So the contents for today will be a brief introduction for mainly with definitions and concepts that are important for my talk to understand. And there will be the latest reviews and the latest meta-analysis I will present today regarding digital interventions in behavioral addictions, and particularly for gambling also. And then I will present one of our recent studies that we completed called Win-Back Control, also a digital intervention. And then we'll have 5 minutes for Q&A. So what might be clear for you is the term apps. So I don't have to explain this, but often I realize that it's not so clear what is exactly mHealth or mobile health, because the WHO defines this as a medical public health practice supported by mobile devices. This can be smartphone, but can be also other devices like patient monitoring systems, personal digital assistants. And for instance, in the alcohol field, there are also devices that measure sweat on the skin. And regarding this, they can also say how much alcohol you actually have or used, for instance, as an indicator. And the other term we were is the internet and mobile-based intervention, because it's important to distinguish between apps and more browser-based interventions that look on your mobile phone also as they were apps, because they cannot just easily be deleted. And this is important regarding treatment when you do it, particularly in the addiction field. The other issue is about the differentiation between guided self-help, so self-help supported by means of, for instance, e-coach or professional counseling in addition to self-help, and this blended treatment. And you know, after COVID, everyone wanted this blended, or at least during COVID, so that the face-to-face part is appropriate combined with online therapy, so that you take the pros from the ones and the cons you try to forget from the other part. So it's like optimization of treatment possibilities. So when you have pure self-help, this is when the patient comes and he or she has an online app or a program on her smartphone or the tablet or so on, then they really have to show it to an addiction specialist, and actually you see there is the first also an issue of data safety that needs to be solved, and sometimes they forget their smartphone and so on. And this was how we started, and then actually we realized guided self-help, that there is some kind of a documentation system that the addiction specialist has direct access to it, and that looks a bit different. So it summarizes the progress from the patient to the client, while the patient client sees more a kind of an app program on his or her smartphone. And the final issue, that what everyone wants, but where we have actually almost none study, there is one now in the alcohol treatment field for blended addiction therapy, but that's the only one so far I know, is that you combine the guided self-help also with face-to-face therapy. And there, of course, you can decide more about targets and patterns, and also decide what is in this situation most appropriate for your specific client or patient. So you usually have this concept of a toolbox where you can decide what out of this toolbox can be taken from. This could be, for instance, a diary of consumption or of gambling, behavioral addiction. This can be self-help modules. This can be also some kind of EMA, so ecological monetary assessment of symptoms, and so on and so forth. So there is now actually some latest review and some meta-analysis where I want to show you what has been found there. We did in our group a review. Actually, we were aiming for a meta-analysis, but we realized it's not possible yet to do a meta-analysis, so stick with a systematic review. And as you can see, we included finally, after the whole process, at least 29 single articles. And of those, and this is really focusing on behavioral addictions, all were with a randomized control design. There was only one exception having a quasi-experimental design. And you see the sample size ranged a lot between 12 and 1100 and more. And across the 29 studies, the percentage of males ranged very largely from 10 to 100%. And so did also the age range. And when you look at the countries, that's always a bit interesting because, you know, we have now also gaming disorder in ICD-11, and there was a lot of criticism that these studies were stemming almost only from South Asia. And when we look at those studies conducted so far, there were most of Canada, followed by Australia, United States, Germany, France, Sweden, so some European countries, and only a few from China, and single studies in Japan, Republic of Korea, and from Israel. And when you look on the topics, then you see that the majority of studies targeted gambling disorder. Other behavioral addictions targeted gaming disorder. There were 3 studies, some on hoarding disorder, one on internet use disorder, and only one on pornography use disorder. When you look at the quality of these studies, and you see there are a lot of red areas. So on the left, you don't have to read it, but are more or less all the studies we identified. You see they have a lot of problems with selection bias. There are problems with blinding in the studies, and also regarding withdrawals and dropouts criteria. So there is a lot to be done, and a lot of space for improvement, one could say. Some colleague of us, the main author was Erickson, just published now a meta-analysis for effectiveness regarding gambling interventions. So not only behavioral addictions, but specifically for gambling interventions. And they included actually all available settings, so also face-to-face and digital interventions. They identified 30 studies finally. Okay, so this is the meta-analysis, and you see that they had actually quite some average effect sizes of 0.71 HSG overall effects, which is good, but of course this is also face-to-face including. When you look at only those studies that were remote for gambling severity, then you see that the effect sizes decrease almost, it's half of it, it's 0.06. But when you look regarding therapist-guided interventions, you see that the effect sizes were a bit larger than when it's unguided. So if there is no therapist in the background, when it's only or mainly self-help intervention. Okay, but back to an example. So we just completed one study regarding an online intervention that was guided in a randomized controlled trial. And why did we that? Yeah, you know, probable gambling can harm individuals' health, relationship, and leave them in substantial debt. There's a high comorbidity, and we thought, well, we don't want only to try to reduce gambling behavior, but also take care of the most frequent comorbidity that has been observed. So speaking of substance use disorder, affective disorders, and anxiety disorders. And you see that the past rate of problem gambling is estimating to range globally very large. So they are huge, actually counter differences. But still, evidence suggests that fewer than 10% of pathological gamblers are in treatment. And of course, only the majority seeking treatment after significant life crisis. Typically, they lost a lot of money and they lose their family and so on. And then they come to treatment. Of course, it makes sense to give them help and provide them treatment before they end up with such a life crisis. Yes. And that's why we wanted to address this with an online intervention. Inclusion criteria, you see, they need to be 18 and above. They have to be quite having already a problem gambling severity index score, so a high score than equal or higher than 3. Of course, they needed internet and access and proficiency also in German or French. They only had a few exclusion criteria, so engaging in other treatments than that one they want to participate, any psychosis or mania in the past 90 days, and severe substance use disorder or elevated suicidality. So this is how it looks like. This was the landing page. It's adaptive for tablets and smartphones. So in the right hand, you see it, how it looks like on a smartphone. And one point I want to show a bit more in detail is that the participants actually had to make some kind of a contract when they started. So it was a contract with themselves. So they could decide to quit gambling, to quit a specific type of gambling, which is specific when you compare to other addictions or behavioral addictions, or actually cutting back, where you also have a kind of the idea of responsible gaming, harm reduction, so that they cut down in the frequency, or also for the money they spend actually. Or of course, quit immediately and completely. After quite some baseline assessment, we showed the participants some personalized feedback regarding anxiety levels, depression, and concentration, alcohol use disorder, and so on and so forth. And depending on this, they were presented with different frequencies of additional modules for the comorbidity. Yes. And also they were presented some gifts that they could have bought more or less by the money they just lost. They entered having lost in the diary. Okay, and these are the modules. So there were 5 modules: an introductory module, risk situation, craving, tackling problems, preserve success. So very classical cognitive behavioral therapy with motivational interviewing. And these were the supplementary module regarding, depending on the scores they had on comorbidity, actually. Then there was a diary where they could enter their targeted gambling time for the coming days, their actually play time, and the balance between wins and losses, and how their mood was. And this actually ended up in an automated graph. Moreover, they were having a kind of a dashboard where there was this e-coach. So this was this Deborah that could always write Deborah and say, hello, I need some additional help, or can you help me with this and that module? And we had also some movies from real players explaining in complex contents what happened to them or what were their problem, and also some additional profiles. As a control group, we used not just a waiting list control group, but this self-help manual designed and already tested for effectiveness and proven effective. The self-help manual Becoming a Winner, Defeating Problem Gambling by David Hodgins. And actually, David was also part of our teams helping us developing the online intervention. So how did we perform? Here see, and this is already quite a good message that you see, we assessed 561 users, and we had to exclude from them actually 49 because of elevated suicidality. So these were all participants that haven't been in treatment so far, lost a lot of money, and actually were really had already some very concrete suicidal thought, at least. And the other message that is important here is it's very difficult to follow these participants up. You see the follow-up rates are around 18 to 27%. Although actually we really chase them with sending SMS, WhatsApp, emails, and so on. Regarding the baseline participant data, you saw that we had more males. The mean age was 33 years old, and the country of residence were mainly from Germany, Switzerland, and some from Austria, and not actually a lot of France, although we had also a French version of this intervention. And now we are already at the main results. So regarding gambling days, you see in both groups, they were actually playing on every second day in the past 30 days. And this goes down after 8 weeks. So after the study end in both actually interventions to around 8 days in the past 30 days. And it remains more or less the same. When we were looking at another primary outcome, so not just the day they spent, but the time spent over the past 7 days, then you see quite a similar picture. There were actually some differences. So it looked like this. In the intervention group, this went more down on week 7 and went also up, unfortunately, but remained similar low at week 24 compared to the controls that received only this self-help booklet. Regarding money spent over the past 30 days, you see that we had in both group large treatment effects, but when you look at within group time effects, there we see a clear difference. So, and you really have to look at it because this is the balance between wins and losses. So they lost actually a lot of money when they started the intervention. And that's probably also the reason why they become a lot of them also suicidal. It went down more in the intervention group, win-back control, and actually it remained also on the longer end. Regarding secondary outcomes, you see that we reached significant group time intervention effects in favor of the intervention group for the problem gambling severity, for the gambling symptom assessment scale. And also that was quite surprising also because we also addressed cigarette smoking. There were reduced more cigarettes in the intervention group. Not really for drinking, but clearly so for the depression and anxiety disorder questionnaires. Okay, let me skip that. I go to this slide. One thing that is important to know is you saw that for follow-up, of course, we used multiple interpretation, we used generalized mixed models and so on. But you still have to be careful to look what distinguishes actually the people that you could not reach for follow-up from those that you could reach. And you see, actually, interestingly, what we expected somehow is that we lose more male than female. We lose more younger people than older people, but all the gambling actually behavioral variables were not differ not between the groups, but the problem gambling severity index, actually there we found a difference. Regarding the comorbidity, you see that actually alcohol drinking days, drug use scores did not make a differentiation, depression also not, but the general anxiety disorders got 7. There we saw a difference, and also in the PTSD symptoms questionnaire. The ASRS is actually an ADHD questionnaire where we did not find any difference either. So there were people with screening positive for ADHD, but they could participate similarly effective in both interventions. So to conclude, one main limitation is, of course, here in the win-back control study that we had high dropout rates in both treatment arms as the main limitation. Both interventions were clearly effective and showed large within-group effect sizes for the main gambling-related outcomes over the past 30 days, as well as many secondary mental health outcomes. However, win-back control was significantly better in reducing money spent, problem gambling severity index, cigarette use, depression, and anxiety symptom reduction, and produced, and that I did not show to you, significantly higher client satisfaction, but of course this we expected from an online intervention when it's compared to a self-help booklet. So given the optimistic results, our intervention is to make the so the intention is to make the intervention freely available for the public health purposes. Actually, we also developed now with some therapists a new version for blended treatment. So the final slide. Thank you for your attention. The study is published when you want to read it in more detail in the Journal of Behavioral Addictions, and in British Medical Journal Open you find the study protocol paper. Thank you for your attention.
Thank you so much. Thanks so much for this great presentation. Before having the questions from our dear participants, I want to express my sincere gratitude to Shao for his great contributions to this event with a powerful scientific start. His expertise and dedication were key to the success of this symposium. Thank you for your outstanding efforts and sharing your knowledge with us, such as win-back control program on gambling addiction intervention. Thank you.
Thank you for
Hello.
the invitation.
And
I'm sorry for the slides. I always have PowerPoint.
It was a great presentation. Thank you so much. Thank you so much being here. Thank you so much for your contribution, and hopefully we will be all together sometime soon in Izmir in our institution. Thank you so much.
Happy to come there. Thank you very much.
If you have any questions or comments, please use the chat box, or maybe also you can send your questions and comments by emails later. Okay, I don't see any questions, but maybe yes, one of our participants is saying thank you so much. Okay, thank you so much, Michael, to be here, to accept our invitation to this online event due to your very intensive program schedule. and I hope we can be together in different programs. And if you would like to say anything, it's some last words.
No, thank you for the invitation. It was a pleasure being here, and hopefully see you soon in Izmir. Okay.
Hopefully.
Okay.
Thank you so much. So now I'm excited to introduce our second keynote speaker, Professor Dr. Carlo Di Clemente, a thought leader in addiction field, who will be shedding light on behavior of change model from University of Maryland, Baltimore County College of Arts, Humanities and Social Sciences, Department of Psychology, USA. Di Clemente is co-creator of the trans-theoretical model. Many of people in addiction field knows it, and his current research projects include assessing the process of smoking initiation and cessation, motivation and status of change. He will be sharing his expertise with us with his presentation titled Addiction and Change, Understanding the Process of Initiation and Recovery. Okay, so the stage is now yours, Di Clemente.
I'm very happy to be here and look forward to kind of working with you. Let's see here. So yes, so we're going to talk today. I'm going to move through this relatively quickly. I don't have a lot of time, but about addiction and recovery. My perspective is always looking at the process of initiation and recovery. So move the slide. So the beginning was about 40 years ago when Jim Prochaska began exploring what people did to successfully change behaviors. We took a clinical psychotherapy perspective. So we looked at lots of different treatments. The issue is lots of treatments, though they're very different, bring the same outcomes, even though they have different philosophies and approaches. And there was also a proliferation of therapies, and yet many people quit addictions on their own. And that was especially true of smokers. And so we wanted to kind of know, how did that happen? Next. And we studied it and built this model of change based on the work that we did looking at smokers and their changing and how they changed themselves. And this model is composed of these three or four different aspects. One is the temporal motivational dimension of change, which we call the stages of change. The other are processes of change. We're not going to be able to talk about much of those today, but these are the change engines that move people to move through the process of change. And then whenever you're thinking about a change, especially in any kind of addiction problem, when you think about the change of one particular problem behavior, you have to think about the context, because the context is really important, because all personal changes happen in the context of that person's life. And the context can be helpful or it can actually hinder. Next. So when we began our studies, we focused on addictions, but we moved quickly beyond addiction because it became a model of intentional change that can be used across a lot of different types of behaviors. And it really does seems to reflect the universal experiences of people who are struggling with behavior change. So it becomes a blueprint that can help us to understand and maybe promote change by trying to by people who are trying to change and providers trying to help them. Next. And the reason that this model has gone viral across the globe and across behaviors is because whenever you think about health promotion or disease prevention, it requires behavior change. So whether I'm thinking about cancer prevention, health promotion, substance use, safety, we either have to start some new behaviors, we have to stop problematic behaviors, or we have to modify behaviors that aren't working for us and causing problems. Next. And basically what you have to think about is where we all want to live as humans in this healthy lifestyle well-being zone is this moderated self-regulated behavior pattern. Addictions are a problem of excess. And we try to kind of move people from excess back into the moderated self-regulated behavior pattern. If we believe that people cannot manage that to stay in a moderated self-regulated pattern with a behavior like we do with a lot of opiate addictions and other kinds of addictions, we want them to go to abstinence. We also have problem behavior or behaviors that we need that were absent, like physical activity, that we want to bring up into the moderated self-regulated behavior. So next slide demonstrates kind of that this model has been used. Go ahead, hit it again. The model has been used with a variety of behaviors. Just click on the slide and it'll keep going. Okay, we're initiating health promoting behaviors, modifying it, increase. And so the model has been used with almost all of these different kinds of behaviors. And to guide treatment, but also to kind of help people understand where they are, or to guide self-help, as you just heard. Many people use this model. Next. So the issue is, how do people change? Well, people will only change voluntarily. Now, I can make people change if I put them in jail or do other kind of things, but people will change voluntarily only because they become interested and concerned about the need for change, convinced the change is in your best interest, and it's going to benefit them more than it's going to cost them, organize a plan of action and get committed to implementing it, and then take the actions necessary to sustain the change. And if you go to the next slide, that's essentially what the stages of change are. The stages are labels: pre-contemplation, contemplation, preparation, action, and maintenance, to try and identify where someone is in terms of this process of change. And one of the big things that happened as we kind of developed the model is we put everybody in the process of change. So if somebody's doing something and is not motivated to make a change, they're in pre-contemplation. But pre-contemplation is a stage of change because the task there is to get people interested and concerned. If you go to contemplation, it's risk-reward analysis and decision-making. If you go to preparation, it's commitment and creating a plan that's both effective but also acceptable to the individual. And then action, we're implementing the plan and revising it, and then maintenance, consolidating change. Go on. Next. There's a lot of misconceptions about the stages. The stages aren't boxes where you put people in. They're tasks that can be completed more or less adequately. It's a logical sequence of tasks, but it doesn't usually follow a linear fashion. So there's regression. Just because I move into contemplation doesn't mean I stay there. I could move back. People get stuck in certain stages like contemplation. And then there's recycling, and we'll talk about that in a minute. The other thing we found that the stages are behavior and goal specific. So the idea is that if my goal is cutting down, then that's really what the stage is for cutting down. And people can be in two different stages with different goals. So a lot of people are in pre-contemplation for quitting, but in action for cutting down. And so it's really important to kind of understand what the goal and the specific behavior is. And then lastly, it's not always a completely rational or conscious process. We're talking about emotions here, values, implicit cognitions. There's a lot of things that go into both the contemplation stuff and the planning and the implementation pieces of that. Next. So let's now go in and look quickly at addiction and change. Next. So from my perspective, here's what an addiction is. It's a habitual pattern of intentional appetitive. So it has to have some pleasurable aspects to it or reach the pleasurable sections of the brain. Become excessive and problematic and produce serious consequences. It's stable. It becomes stable over these problematic behaviors over time. Many of the smokers we worked with were smoking for 20 years, the same pattern or more. There's interrelated physiological, psychological, and social components. And then addicted individuals have difficulty modifying and stopping these behaviors. That's almost a prototypic definition of that. And it doesn't matter what the behavior is. It could be gambling, like you just heard, or it could be smoking, alcohol, marijuana, heroin, or any of the process addictions. Next. But if you start thinking about addiction in the context of the process of change, what you realize is both initiation and recovery from addiction require a personal journey. That journey goes through an intentional change process that's marked by both personal decisions and choices, but it's also influenced by biological. We know there's a neurobiological effect of many of the addictions. There's psychological factors and there's social factors that influence this process. So the journey of change can help us understand addiction and recovery. Next. So this is how I look at addictions. And when you look here, you'll see at the top part, you'll see this is the process of initiation. People move from pre-contemplation through this process of contemplation, preparation, action to develop a pattern of behavior that often for addiction and to qualify as a substance use disorder, it's usually dependence and moderate to severe use disorder. Once they're there, people end up kind of in pre-contemplation for changing because they've built a solid, well-maintained behavior. And then we have to move them through the stages of recovery. And what we found is that similar processes, context, and markers of change work whether we're talking about initiation or whether we're talking about recovery. They may operate a little bit differently, but they work the same. Next. So when we think about it, as individuals move through stages of initiation, they go from thinking about it to experimenting to developing a pattern that becomes habitual over time. Now, it's important to distinguish, as we said, the last speaker said, pathological gambling is a small percentage of the people who actually gamble. So many behavior patterns are acceptable or at least legal and don't create problems or get judged as excessive. So lots of people socially drink, lots of people gamble, go to a casino and gamble. There are people who smoke, even though it's not advised. And then we have medical marijuana. So many of the people using some of these substances are doing it in an acceptable fashion, and so we don't call it a disorder. Addiction is best understood as a well-maintained problematic pattern of engagement. That's when it gets established. Next. So when you look at this is the stages of initiation. And you can think about, there's a lot of things that are happening in the early stages. People have expectancies and beliefs about certain substances. There's personal environmental pressure to kind of personal concerns to kind of move people out of pre-contemplation. There's decision making. Then there's people begin casual use. Then once you start beginning more regular use, that's when brain and physiological changes kind of kick in and develop into dependence. And you'll see that genetic and biological risk have a much more of an influence in the early phases as you kind of see people being more vulnerable. Peer and family influences affect that initiation all along the way. Next. Yeah, so basically the other thing to realize is that people can be in different stages with different behaviors. So this is just a picture of a woman, Elena, who is in maintenance, so regularly using vaping nicotine and using marijuana and vaping marijuana, is beginning to kind of create an alcohol problem pattern of use, but she's beginning to drink and do that kind of stuff. She's only dabbled with amphetamines and is concerned about her body image, and so has been thinking about kind of how can she kind of manage that. But she's in pre-contemplation for some of the other substances. So I think it's important to realize that stages are behavior and goal specific. Next. Does this matter? Well, this is just, I just wanted to show you a picture of, this is the middle school and high school surveys. These are like 20,000 kids in the state of Maryland. And you'll see that in middle school, there's a lot more kids in pre-contemplation and very few who move into maintenance. When you get into high school, you'll see that 32% of the high schoolers are in pre-contemplation for alcohol. So a lot of them are considering it, using it, testing it, and then you'll see that there's over 30% who are actually in action or maintenance. And in marijuana, that's also true. We have fewer cigarette smokers than we have marijuana people who have used marijuana in high school or are using it more regularly. Next slide. So why is that important? It's important because we need to think about prevention. And if you start thinking about prevention, it depends on where the people are in who you're trying to address, where they are in their stages, in order to tailor your messages to that where they are. So messages that you do for population prevention won't necessarily work for at-risk prevention because those folks are already engaged. So we need to be thinking about the different aspects of prevention and how we can do that based on kind of how we see the stages. Next. So if you can't prevent the substance, then you a substance use disorder initiation, then you develop this problematic pattern, and it can lead to a stable, sustained pattern of behavior that's difficult to modify. Moderate to severe substance use disorders. And I just wanted to mention, go ahead next, the couple of mechanisms that I think help people do that. Next slide. So the key mechanisms of addiction that I think happen are these: neuroadaptation, the brain changes as you expose it to these substances; impairment in self-regulation, the loss of self-regulation contributes to becoming a use disorder person, just as we talked just earlier about ADHD, but also as you become more developing this substance use disorder, it gets worse. Your self-regulation gets worse. And then finally, there's a salience or narrowing of the behavioral repertoire. Substance use and addictive behavior take over the life space. It becomes more important and other activities become less important. And so treatment needs to address all of these different mechanisms when you're dealing with the substance, a substance use disorder. Next. The important thing is that all of these mechanisms impact motivation and behavior change. So neuroadaptation and salience really interact with ambivalence and decision-making and commitment. Impaired self-regulation influences our coping abilities and the ability to delay. Context offers resources and creates chaos. So all of these mechanisms interfere with the process of individuals making a change and quitting a substance use in terms of recovery. Next. So again, once we get there, we need to be thinking about moving them through the stages of recovery. Next. And you'll see it's a very similar pattern. We need to think about what we found is that the cognitive and experiential processes are more important early and behavioral processes later. It may be the reason that there's cognitive behavioral therapy seems to be the hallmark of how we kind of are working with people with substance use disorders and actually with behavior change. Next. So we need to kind of clearly make a distinction between what's the difference between what's the client's work and what's the provider's task. From the transtheoretical perspective, the client's work are these processes of change, the coping activities, and the tasks of the stages of change. From the provider, they offer strategies and services to actually support client processes. And you'll see this in the next slide. So our interventions are really engaging some of these processes, which then affect interest and concern or decision making or planning or whatever. And life context and social influences also influence that. But our interventions don't directly impact interest and concern. It has to engage the client in some of these processes of change. Next. So the change, we have to promote change. You have to kind of think about how am I going to engage the client in these different kinds of things in pre-contemplation, contemplation, and then shift my strategies to engage clients in these other activities and processes during preparation, action, and maintenance. Next. We would love to see the success to look like the picture on the left, right? That, we tap somebody on the shoulder, they kind of say, that's a problem. We say, oh yeah, I knew that, I'm going to change. And they change and it's all over. Success is really messy. And I've been doing a lot of work recently looking at relapse and recycling. Next. So the issue of relapse is interesting because relapse is probable with any health behavior. So it doesn't matter whether it's diabetes, diet, exercise, or substance use. And often the rates are the same for the addictive behaviors as they are for some of these others. So relapse is not a problem of substance use. Relapse is a problem of instigating and sustaining behavior change. It's an instance of what we call in psychology successive approximation learning. It's how we learn most things, is by trial and error. Okay, and the trial and error here is learning how to adequately complete the critical tasks of the stages of change. So that's the perspective of the model. Next. Originally we thought of relapse as a stage, but it's not. It's an event that happens that helps trigger this cycle. And the cycle of change, is interesting because I think people can understand. People kind of move through this cycle sometimes multiple times. Hopefully it's a spiral moving upward to success if you're really learning how to do this well. And ultimately moving out of maintenance into termination. Next. So what are the keys to successful recycling? Well, persistent efforts at getting the tasks done well, figuring out how to do this better. And even people who quit on their own or do self-change or self-guided change have to do this. Repeated attempts, learning from the past, recovering from neuroadaptation, finding support for your self-regulation that's impaired. And I use that term scaffolding. I can't go into that now, but it's building support systems that hold the individual and support the individual, support their impaired self-regulation. And then you can't just take away something, you have to build a new life. That's self-directed and have meaning. That's actually the definition that SAMHSA gives to recovery. And the last important thing is never give up. And that stick and stay came from a client who, a pregnant mom who delivered a exposed baby. And she said, I said, what would you say to other moms? She goes, just stick and stay. You got to stay with it. You got to stick. You don't always want to do this, but you have to kind of keep going for the good of your baby. Next. So I think that gives you a very quick run through. I think I actually stayed inside my time right there in terms of doing that. And so if you have any questions or comments, these are some of the books. Addiction and Change is the prototype book that I used, that I presented from. We have developed a group treatment for substance abuse, substance use disorders with colleagues. We have a book with substance abuse treatment in the stages of change that Gerard Connors did, and a number of us. And then I always like this Rethinking Substance Use, Bill Miller and Kathy Carroll. We all have, the number of us have chapters in there that really talk about implications of our work and the different aspects of substance use disorders and how to address them. Thank you.
Thank you so much. Thank you so much, Professor Dr. Carlo Di Clemente. On behalf of my institute and all the participants, I want to extend a heartfelt thank you to our speaker, one of our keynote speaker, Di Clemente. So your contribution on addiction and recovery as our keynote speaker is really, really important for us. Maybe we have been growing with your experiences, prior experiences, and also your contributions, and also in a very unique way, you talked about the addiction and recovery and what is addiction. Thank you so much for this opportunity for us, and thank you for your time, wisdom, and inspiring words.
Yeah.
Görkem, please.
Professor Di Clemente, this is a very special moment for us because we benefit from your articles a lot. All of our PhD students, master students and all of us are experienced that. And so this is a very special experience. Thanks so much for sharing your experience and knowledge with us. Hopefully, we will be very happy to welcome you in Izmir Ege University for a meeting specialized on addictions. Thank you so much.
Oh, you're very welcome. Very welcome.
Thank you so much. If you have any questions, last chance. Okay.
I made everything too clear, so it's all clear, so nobody had any questions.
I'm sure.
Yeah.
Dear Duygu, Duygu is asking that my second question is, could you recommend any resources that combine TTM and concepts such as self-efficacy in graphs within your presentation?
I think she has two questions, huh?
Yes, and also thank you for the I would like to ask whether there are any valid and reliable scales to assess stages for initiation of addiction. This is our first question. Sorry.
Yeah, well, I don't know that there's good scales. We have set up a system of questions that worked in that. We have published some of that information about initiation with the Maryland data. I'm not sure if we have, I think we have some of the information in the book, Addiction and Change. They have been trying to kind of develop measures that work for initiation, but it's really, you have to kind of think about exposure, and then you have to think about attitudes and intentions. And so you have to put those two things together to make sure you get pre-contemplation. So you can have people in pre-contemplation now who never tried it, but you can also have people in pre-contemplation who have tried it and decided to be in pre-contemplation. And then when you get down to the other end, action and maintenance, we define action as a regular use of some kind or other, even if it's weekly. And maintenance is regular use for 6 months or more. So in the study that I just showed you, that's how we've kind of defined that. And if you need, you can send me an email and I can send you maybe a paper or something that related to that.
Mm-hmm. And also her second question, maybe you answered a bit maybe, but is there any recommendation from your side in resources that combine TTM and concepts such as self-efficacy in the graphs within your presentation? She's asking.
Not in the graphs in the presentation, but yes, in the graphics, but not the graphs. In the graphics, there's efficacy is very important toward the end part of it, and decisional balance is more important in the beginning aspects of the process of change and the initial stages. So we always think about decisional balance and self-efficacy as important aspects of that process, and as a mark, we call them markers of change. And self-efficacy and temptation and self-efficacy are very strong predictors of outcome. And again, if you ask me, I'll send you an article that we did that shows that.
So thank you so much for this moment, for this hour and presentation. And I hope we can be in other kinds of organizations. Thank you.
Thank you.
Have a nice day.
Reach out and I'll see what I can do.
Thank you. Thank you so much.
Bye.
Dear participants, thank you so much for your attention until now. So we are moving to our the third keynote speaker, Professor Dr. Reinhard Michael Kraus. And it's with great pleasure and anticipation that I stand before you to introduce our distinguished keynote speaker for today, Professor Dr. Michael Krause from the University of British Columbia, Faculty of Medicine, Canada. Professor Krause is a psychiatrist specializing in the comorbidity of severe mental illness and addiction. His research primarily focuses on psychosis and psychotropic substance use. He will be sharing his expertise with us today with his presentation titled Psychiatry and the Most Vulnerable, Innovative Ways of Service Integration in the Community and Virtual Care. With great excitement, I turn the microphone over to dear Krause. Please.
Good morning, from British Columbia. Are you shifting the slides, or shall I do that?
Which you prefer? We can assist you.
Could you do the slides?
Of course. Could you help us, Hassan, please?
Of course. Thank you. I'm doing it.
Thank you. It's my great pleasure to join you in Izmir, which is probably much warmer than it is right now here in Canada. And I want to talk to you and present to you from a very special perspective right now, starting with the specific needs from psychiatry. I want to so after hearing a very important and interesting psychological perspective, I want to especially address two points, and that one is to start from the current crisis we have in North America related to high potent opioids and overdose mortality. And second, the correlation of substance use and complex concurrent conditions. Because the point to understand with high-risk substance use is that it is nearly never coming alone. It is always connected to mental challenges of several kinds, and I want to share those with you and how to respond to that in an integrated manner. The point is, and the situation is very dramatic, that right now in North America, thousands are dying due to a high potent opioid, especially fentanyl, becoming the most prevalent and most important opiate on the streets. And I think this is nothing we can ignore. We need to be aware of, and I heard that also in Turkey, some incidents with high potent opiates occurred, and it's becoming a discussion point. In British Columbia and in Canada, it is becoming extremely concerning, given that right now British Columbia is the #1 space in the world which has the highest number of overdose fatalities compared to the number of citizens. So the question is, how is that related? So we are under the pressure to really respond to it successfully. That was complicated. Okay, could you move on? Next, please. Okay, that's me. And that's, Janos. But let's move on. I can't explain that story because we don't have that much time. Okay, I'm obviously in Vancouver. I'm the leadership chair of addictions research, and I'm doing a lot of international work, which I don't document here. Please go ahead. And the situation I'm describing starts with this slides. We have about 8 overdose fatalities every day in British Columbia, which is a region of Canada with about 5 million citizens. Go ahead. And we are experiencing a dramatic situation overall, which I will demonstrate with a few numbers. Could you go ahead, please? Yeah, you see, since several years, 2014, we have a steady increase of fatalities in British Columbia. Please, we have 20 times more people dying, for instance, per capita than in my home country, Germany. Next, please. Okay. Yes, I wanted to talk about the interconnection between substance use disorders and concurrent mental illness as a growing burden of disease, the response of psychiatry and the impact of substance use on the future of psychiatry, and what we need to do to respond to this crisis. Next, please. Yes, this is how it looks on the streets of Vancouver at night, especially young people increasingly becoming homeless. Social determinants of health are absolutely interconnected with intense street drug use and need to be addressed. You can't recover from anything living like that on the street. Next, please. Uh-oh. Yes. So what I mentioned, we have 10 times, 20 times higher mortality than other countries. We have a complex morbidity. The majority of patients in emergency rooms in general coming with mental health conditions are actually suffering from both, from substance use disorder and complex concurrent disorders. And the burden of disease in this area is growing without the ability to address their needs in appropriate healthcare. Next, please. And the less healthcare you have, the more ineffective the response is, the higher the mortality rate. What I just wanted to document through that, if you look at mental health and substance use on a population level, then a lot of them are separated. The closer you go into the area of acute care and into the system of care, the more you see that the highest needs are represented by the population with high-risk substance use and complex concurrent disorders. 70% of people in emergency rooms, which are then admitted to acute care, are admitted because of both severe mental health problems and severe substance use. Next, please. And this is a very important thing for our healthcare system, because you not just have to handle one. You can't just focus on the substance use side of things. You also need to think about the suicidal aspect, for instance. So in the most recent number related to overdose in the US, analyzing US data and coroner data, they found that 50 to 20% of the overdose cases were suicidal in nature. And as you probably know, there are lots of discussions over decades about the role of suicide in this field. Next, please. Trauma is another one. 2/3. Could you move on, please? Psychosis is increasing, especially, now it's getting very fast, because the amount of stimulant use, which is interacting with opioid use, and then mood disorders, anyhow, the most prevalent mental health condition among substance users. Next, please. And we are moving towards impairment, cognitive impairment. You have very specific syndromes which are not to be underestimated, which lead to cognitive impairment and lack of functioning in society, especially related to alcohol use, but also to substance use. Next, please, to drug use. Okay, this is how it looks in some of the downtown east side Vancouver apartments. This is a patient with a bipolar disease and heavy substance use. And you see that living conditions are unacceptable, but also it's unacceptable that most of them don't get appropriate care and attention in the healthcare system. Next, please. Okay, it becomes more or less this, what I just tried to describe, becomes a new normal in our society. So in psychiatry, and psychiatry very often neglects substance use as a challenge and as a problem. Substance use in combination with mental conditions is becoming the new normal. Complex concurrent disorders are the new normal in acute mental health care, but they're not. Our residents are not trained appropriately in med school. It doesn't really play a significant role, and in the development of innovative treatments, the same. And I will make a few remarks at that in the end. Next, please. Yeah, that leads to about, for instance, in British Columbia, and especially in the lower mainland of around Vancouver, over 30,000 ambulance activities and calls because of overdose incidents. It's not an exception. It's a everyday topic. Please, next picture. So again, a few number in the US in the last year. Sorry, numbers here are a little too old. So it doubled already. So there's last year was over 110,000 fatalities in the United States alone. Next, please. And drugs involved in overdose incidents were especially synthetic opiates, which especially in Vancouver and in Canada are fentanyl derivatives of fentanyl itself, but not alone. So it is a new development which needs to be acknowledged that opiates are changing, are produced in the countries and not imported, and synthetic opiates are changing on a very short time range. Next, please. Okay, again, we can skip that, please. It's just documenting that the number of major causes of unnatural deaths in British Columbia are shifting towards overdose. It's already having an impact on life expectancy of the population, which shows you something around the next, please. Yeah, this going along with a big discussion we had around prescription drug use. The medical use of opiates increased over the last 10 years dramatically, especially in North America. What you see here, very interesting, is the United States and Canada are using the most morphine equivalents, and then Germany is on third. Interesting thing to comment here, and that's the reason I brought this slide, is that Canada and US have a significant overdose crisis. Germany doesn't, which must be a hint that this is related also to the opioid stewardship and to the way pain treatment is organized, to access to prescription drug use. But prescription drug use alone is not an explanation for the current misery. Next, please. It is mainly, it's mainly an important thing. There is a prescription drug use abuse, which is something to address. But the main thing is we have changing drug markets. And the dominant substance right now are not morphine level opiates. They are high potent opiates like fentanyl, with 25 times more potent than heroin. Next, please. The reason for that is also, for instance, if you had experienced an overdose situation, let's say 10 years ago with heroin, you had 3 hours to respond medically and to save lives. Now you have 15 minutes to save lives and to respond to a fentanyl overdose. That is also an important point to keep in mind, which is a big challenge for the emergency system and the healthcare system overall. So you need really to learn or revive your emergency capabilities. Next, please. Okay, we can skip that. Sorry, all the fancy slides are a little slow. So she is so that's what I want to say. The overdose crisis is not only focusing on one problem and one drug. It's a new class of drugs, high potent synthetic opioids with higher potency, which lead to higher mortality rates. Next, please. Okay, yeah, could you click again, because I want to show you the relation between heroin and fentanyl. These are equivalent doses of opioids. Heroin is obviously much lower potent than fentanyl, which makes the handling nearly impossible, and makes very often that also the mortality level is reached without control of the user. Next, please. Okay, why is the response so far not successful to the overdose crisis, and what do we need to do and in terms of developing the system of care? Next, please. The system of care needs to, as you see on this slide, needs to work on all levels of treatment. This is opiate substitution treatment. This is a graph from 2017, but it didn't change much. United States and Canada are at the lower end of substitution treatment, and you find a direct correlation between patients in treatment, because every OD treatment is reducing opiate tolerance, and you can really save a lot of lives through including patients into OD treatment. Next, please. Okay, the quality of care is the most important indicator to understand difference between countries, but also it comes with another very important point, and that's the dynamic of specific drug markets. If you have some synthetic opiates on your streets, then the probability that these are produced in your own country are pretty high there, because like with methamphetamine, fentanyl can be produced directly regionally. Next, please. Okay, this is just a paint to show you a broad picture probably 5 years ago in different continents. You clearly see North America is the worst, and then Latin America is much better off, especially because the opioid use is very limited. They are mainly using stimulants and cocaine, but it shows you in one, also the amount of resources and money is not really related to better healthcare and to better outcomes. Next, please. Yeah, what is the emergency response? What does it need to look like? Next, please. Okay, the first thing is in any kind to address mortality is probably the most important outcome we want to achieve, is you need to do something for survival. So we have big campaigns here distributing naloxone kits for free. But if you have high potent opiates, maybe that one naloxone wouldn't do the trick. So you need to train people to be prepared to a very complicated and very threatening emergency situation. Next, please. Beyond the emergency, you need to start working on access to care, building capacity, especially in substitution care. And what I want to highlight also to develop methods of opiate prevention, opiate overdose prevention, especially using new technologies. Next, please. We developed a platform for that, which is entangled with other essential treatment methods, but you need to have these essential methods in place and easy accessible, because there's very little time to response. And where I started, you need to combine the treatment of the complex concurrent disorders like suicide, like trauma, like depression, together with addressing substance use. Otherwise, you won't see any recovery. Next, please. Okay. If you look into different, especially European countries, you see it's also enormous differences that's the same. The overdose crisis is starting to happen also outside of North America, and I see no reason that the dynamic of drug markets will spare the European continent. Next, please. Okay, I will stop with this slide because I think I'm in time pressure. So we are in a situation which is in an absolute crisis, which demonstrates to us that we need to adapt our healthcare system, and we also need psychiatry to play a core role in addressing a situation where severe mental illness and high-risk substance use are combined, and you will only achieve any progress, any sustainable recovery if you address both in a sustainable way and use new technology to do that, if you use psychosocial intervention in addition to a good pharmacotherapy. Thank you very much, and happy to answer questions if there are any. Thanks.
Thank you so much, dear Kraus. Thank you. If you have any questions or comments, please feel free to use the chat box. As we conclude this remarkable presentation by Professor Kraus, I'm filled with gratitude for the wealth of knowledge and insights shared. Thank you. You have highlighted many important things in this very short time. Some of those are that you highlighted overdose epidemics happen in countries with an insufficient system of care, and one of your conclusions is the overdose crisis is not only related to a single substance, it's not just a fentanyl crisis, so it's part of an deteriorating risk constellation, right? And your presentation is not only being informative, not only rates and glow rates, but truly inspiring each of us maybe. And thank you so much for sharing your time, your presentation with us. And if you have any questions or comments, also you can send emails, or maybe in the future we can do any kinds of organizations to be together with our students, with our professions in Turkey. And so we are very interested in different and new approach and new solutions. So it's really delighted for us, appreciation for us to be with you. For us at the evening, and for you, I think it's an early morning, right?
It's a very early morning. Yeah, I didn't have breakfast so far. Yeah.
Oh, okay. Great.
Okay.
Thank you so much. Thank you so much to be with you. Bye. Take care. Take care. Thank you. And thank you so much for all keynote speakers and for all our participations, attentions until right now. And now we are moving to our guest speakers' presentations. So, ladies and gentlemen, as we come to the culminating moment of our symposium, it's my distinct honor to introduce our guest speaker for her speech from the University of Massachusetts Amherst from the USA. Heart and Voices interest mainly consists of evidence synthesis work with a focus on health behaviors, long-term conditions, and new and complex methodologies. Today, she will talk about the latest evidence from the Cochrane review of e-cigarettes for smoking cessation. And so the stage is now yours, dear Heart and Voice, Jamie.
Thank you so much. I'm not seeing an option to share my screen. Should I be able to see that option in order to get my slides up?
Maybe, are you seeing 3 dots?
I am seeing my 3 dots, and when, sorry everyone for listening to this,
it's okay.
when I go into those dots, sharing my screen is not an option.
Maybe because of the versions of the program, or we can share your presentations during, and we can give authority. Is it possible, Hassan, for that? Or how can we help?
No, I think we can't give authority right now.
So maybe we can share on behalf of
Do you want to
you.
share on my behalf, and I'll just say next? Great. Thank you.
Thank you.
Okay. Let me share the presentation.
Thank you.
Maybe you can share your screen again. Not
Yep.
by, not by uploading.
I'm sharing it. Can you see it right now?
Yes.
Oh, and now I do have a take control of the presentation option, so I'm going to go ahead and take control if that sounds okay to the organizers.
Of course.
Great. All right. Well, thank you everyone so much for having me here this evening your time and this morning my time. I want to talk to you about our most recent update of our Cochrane review of electronic cigarettes for smoking cessation. My slides. Let's see. I cannot. Oh, there we go. It's just jumped ahead. Don't know what's happening. There we go. So in terms of funding, the work I'm presenting today is supported by Cancer Research UK, as well as the National Institute for Health Research in the UK, and we don't have any conflicts of interest to declare. If someone else could press next, because it's just not letting me do anything. Awesome. So for anyone unfamiliar with Cochrane, Cochrane is a global nonprofit that exists essentially to conduct massive systematic reviews. Oh, sorry, go back one, please. We do this by gathering and combining the best evidence from research in order to determine benefits and risks of healthcare treatments and healthcare interventions. We are very much kind of subject agnostic. So what that means is that Cochrane has a big handbook with a list of methods that Cochrane reviewers follow no matter what topic they're looking at. So it doesn't have to be e-cigarettes, it doesn't have to be tobacco. It could be something like antibiotics for skin infections, or in our case, it could be e-cigarettes to help people stop smoking. And the way we do this is we systematically review all of the available evidence on a topic with a really strong focus on quality assessment. So we're thinking not just about what does this research show us overall, but how much can we trust the research that's been conducted. Because of the methods that we use, our reviews are widely considered gold standard. And the reason we do these reviews isn't to make any recommendations for what anyone should do. We do them to make sure that anyone who's making a healthcare decision, whether it be a provider, a patient, a carer, a researcher, a funder, a policymaker, etc., can do so with the best available evidence to hand. Next slide, please. A few years ago, our Cochrane review of electronic cigarettes transitioned to a living systematic review. So Cochrane reviews are regularly updated, and we first published this review back in 2014 when there were only 3 trials that looked at giving people who smoke e-cigarettes. This evidence has moved on a lot in that time. It's been a very active area of research. And what we were finding was that our review kept being out of date. It didn't have the most recent evidence in there. So we got additional funding from Cancer Research UK to transition over to this living systematic review approach. And what that means is that we search for new studies that are relevant to this review every month. We publish links to those every month, and we update the full review whenever new data emerges that might change, strengthen, or weaken our existing conclusions or relate to new comparisons or outcomes. So basically, if something comes out that we think might change what someone does on the back of our review, we go ahead and update the review. Next slide, please. The objective of this particular review is to evaluate the safety and effect of using e-cigarettes to help people who smoke achieve long-term smoking abstinence. So what happens in these studies is that people who smoke are given an e-cigarette with the explicit instruction to use it to either help them quit smoking or help them, what some people might say, switch completely over from smoking to vaping. And to be really clear about the terminology I'm using here, when we talk about smoking, we mean something that happens when we burn combustible tobacco, and that's what happens when people smoke cigarettes. And we know that smoking is the leading cause of preventable death and disease worldwide. But actually, what we also know is that the things that are causing all those harms directly, the things that are causing cancer and heart disease, are coming from the process of burning. Sorry, previous slide, please. I don't know what's happening. And not from nicotine. And so when we talk about vaping, we're talking about heating a liquid that contains nicotine, but you're not burning anything. So you're not producing as much harmful substances. And that's why we talk about smoking and vaping, or smoking and using e-cigarettes as very different things. In terms of the studies we included, we looked for randomized controlled trials or uncontrolled intervention studies in which people who smoke are given some sort of an e-cigarette intervention. And the main outcomes we're interested in are how many of them have quit smoking at 6 months or longer, so are abstinent from combustible cigarettes, and also measures of harm at 1 week or longer. So those include things like adverse events and serious adverse events, as well as changes to biomarkers and levels of toxins in the body. Next slide, please. We have a lot of comparisons in this review, and as anyone who's read a Cochrane review knows, they're incredibly lengthy and detailed documents. I'm not going to go into all of our comparisons today. So to orient you, I want to say that I'm going to focus on our 3 primary comparisons, which compare nicotine e-cigarettes to traditional nicotine replacement therapies like patches or gums, nicotine e-cigarettes to behavioral support only or no support, and nicotine e-cigarettes compared to non-nicotine e-cigarettes, which is a slightly odd comparison, but it's the most similar thing we can get here to a placebo-controlled trial, because essentially what you're doing is you're removing the active pharmacological ingredient. In terms of those outcomes, for cessation, we're interested in how many people quit smoking at 6 months or longer. And I won't go into the details of this, but we use a very conservative estimate for this. So if people haven't followed up, then we assume that they are continuing to smoke, and where things have been measured to test that they're reporting accurately whether or not they quit smoking, we use those measures. For adverse events and serious adverse events, we use definitions provided by study authors, but broadly what this means is an adverse event might be the kind of thing that's a side effect that might be unpleasant enough that you stop using a product, but is not going to threaten your life or well-being in a serious way. Whereas a serious adverse event is the kind of thing that might land you in hospital, it might change your life, it might threaten your life. And we're also interested, but I won't present today because it's a secondary outcome, as I mentioned, changes in relevant biomarkers. So those are things in your blood, breath, and urine. What I'm going to present to you today is actually not published yet. It's the results from our most recent update. So everything from here on in is somewhat confidential, and really importantly, it is possibly subject to change. Sorry, previous slide. Don't know what's happening. But the data we have today are up to date to February 2023. We searched 7 electronic databases, we contacted researchers all over the world, and we searched trial registries, conference abstracts, and ongoing studies for any new information about e-cigarettes for smoking cessation. Next slide, please. So in this most recent update, which should be coming out in the next month or so, it's just going through the publication process currently, we have 88 included studies. 10 of those are new to this update, and 47 of them are randomized controlled trials. All in all, this represents data from around 30,000 participants. But most of these studies are limited in that they're conducted in the USA, so 38 of them, followed by the UK. So really 2 countries massively dominating this evidence base at the moment. Unlike other studies of things that are given people to help them quit smoking, these studies are a little bit different in that a lot of them only recruit participants who aren't motivated to quit smoking. So they are only interested in people who don't want to quit smoking or have tried before, but it's never worked for them and they're not willing to try again, but they are willing to be part of a trial where someone gives them an e-cigarette. And that's important because those are the people who we know need more support to help them quit smoking and for whom I think people think e-cigarettes might be a really viable option. 3 of our studies exclusively recruited or included people who already were using e-cigarettes as well as smoking. And the goal of those studies was to transition the people off of smoking, but to allow them to keep vaping. And we know that not all e-cigarettes are the same in any way. So previous slide, please. The technology itself has evolved a lot over time, and there's always a bit of a time lag between the devices that are being used currently and the studies that are being published. And that's because it takes a long time to get funding for studies, to conduct it, to analyze it, to report it, and to get it published. And with something like e-cigarettes, where the technology is moving so quickly, it can often be the case that by the time a study is published, the device that it tested is no longer available. So of our included studies, 31 used what are called cartridge devices, and those are pretty much the oldest type of e-cigarette. 34 used refillable, which are also fairly uncommonly used now. 4 used a combination, and 7 used what are known as pod devices. The most commonly known pod device is Juul. So that is a commonly used thing, and we're finally seeing a few more studies come out there. But what we don't have any studies on yet now are what are known as disposable or single-use e-cigarettes, which are now one of the most commonly used things, particularly among young people in many countries. Next slide, please. So moving on to our results, when we compared nicotine e-cigarettes to nicotine replacement therapies and looked at how many people quit smoking at 6 months or longer, we found that more people quit smoking using a nicotine e-cigarette than using traditional nicotine replacement therapies like patches or gum. As I mentioned in Cochrane, we don't just want to look at what the evidence shows overall, we want to think about how much we can trust it. And we do this using something called GRADE. It's a framework that's used not only in Cochrane, but among many national and international guideline developers and journals to judge how certain we are in the evidence. And the highest level of certainty we can have is high certainty according to GRADE. And what that means is that we think further evidence is very unlikely to change our overall conclusions. And this evidence is high certainty. So that means we think the evidence that is going to come out in the future is going to be very likely to support this finding that nicotine e-cigarettes help more people quit smoking at 6 months or longer than traditional nicotine replacement therapies. Next slide, please. We were less certain simply because we have less data around adverse events, but the data that we do have suggests there's no difference in adverse events when we compare people receiving nicotine e-cigarettes to people receiving nicotine replacement therapies. Here, this is considered moderate certainty evidence, and this is because of something called imprecision, which basically means we don't have that many studies contributing data. And of those that we do, some of them aren't very big. So statistically speaking, we don't have a really precise answer on that yet. Next slide, please. When we compared nicotine e-cigarettes to nicotine replacement therapies, here we had low certainty evidence, which means that we think further studies could really change our conclusions. We don't see any clear evidence of a difference between nicotine e-cigarettes and nicotine replacement therapy in terms of serious adverse events. For those of you familiar with forest plots, you'll see that our confidence intervals include no statistically significant difference. So these findings are not statistically significant, but One of the good things, sorry, previous slide. One of the good things about these studies is that we have relatively low rates of serious adverse events occurring in either arm. So we have some studies here where no one is experiencing any serious adverse events during the study that might land them in hospital. That's great news for the people in the studies, but statistically speaking, it makes it really difficult for us to say if what we're seeing reflects some underlying truth in these studies or is just due to chance, because we essentially are very underpowered to detect a difference here. And this is something that will need to be continually monitored. Next slide, please. So moving on, when we compare nicotine e-cigarettes to non-nicotine e-cigarettes, or in other words, to placebo, we again find more people are quitting smoking at 6 months or longer when they're using nicotine e-cigarettes compared to non-nicotine e-cigarettes. Here, our certainty in the evidence is moderate, and this is again because of this issue with not that many studies. So essentially, we're still a little bit underpowered here. And so future studies could change our conclusions. And in terms of adverse events, we don't see any evidence of a difference when we compare nicotine to non-nicotine e-cigarettes. But here again, our certainty is limited by imprecision. We don't have that many studies reporting data on this, and more studies could change our conclusions. And in terms of serious adverse events, very similar story here. We have a lot of studies that have very, very few events happening in them, which again is great for the participants. But statistically speaking, it means we can't rule out no difference. There could definitely be a difference here, and we could just not be seeing it because of underpowered analyses, essentially. Next slide, please. Finally, our third comparison, when we look at nicotine e-cigarettes compared to behavioral support only or no support, to clarify what I mean here is that these are trials in which everyone is given the same level of behavioral support, whether it be intensive counseling or like nothing. And then one arm is also given a nicotine e-cigarette. And here again, we see clear evidence that more people are quitting smoking when they're given a nicotine e-cigarette than when they're not. Our certainty in this is low, and this is due to something called risk of bias. So in Cochrane, we assess each study to see how much we can trust it. And according to Cochrane guidance, if one arm is receiving more than another arm, that automatically biases the results. And in this case, this will always be the case. One arm is receiving nicotine e-cigarettes and the other arm isn't receiving active intervention. And so for that reason, this evidence will always essentially be low certainty. But it's worth saying that when we compare nicotine e-cigarettes to nicotine replacement therapy, we see a positive impact. When we compare nicotine e-cigarettes to e-cigarettes without nicotine, we see a positive impact. So we would absolutely assume that when we compare nicotine e-cigarettes to nothing or behavioral support only, it would make sense that more people were quitting with those nicotine e-cigarettes. Next slide, please. We found a slight increase in adverse events. So these are those side effects that aren't going to be life-threatening or life-changing, but might be really annoying when we compared nicotine e-cigarettes to behavioral support only or no support. And typically those side effects were things that we also see in trials of nicotine replacement therapies, which include sometimes disturbed dreams, sometimes nausea, and also irritation at the site of administration. So for example, with a patch, that might be skin irritation. With a nicotine e-cigarette, it might be throat and mouth irritation. Previous slide, please. What we did find when we looked further into the data on adverse events was that, like in studies of nicotine replacement therapies, these tended to dissipate over time as people got more used to using the device and more accustomed to the side effects that came along with it. Next slide, please. When we looked at serious adverse events, we found no clear evidence of any difference. But here our certainty is very low. We have the same issue with risk of bias in these studies, as well as here a lot of studies reporting no events or very low number of events occurring, which again, it's great that they're rare for participants, but statistically speaking, leads to a lot of uncertainty for us. Next slide, please. So all Cochrane reviews end with implications for practice and implications for research. And I just want to summarize those for you before I open up for questions. So we have evidence suggesting that nicotine e-cigarettes can help people quit smoking, and that's consistent across our different comparisons. There's high certainty evidence that e-cigarettes with nicotine increase quit rates over and above traditional nicotine replacement therapies. Moderate certainty evidence that e-cigarettes with nicotine increase quit rates compared to non-nicotine e-cigarettes. That's kind of your placebo test. And low certainty evidence limited by risk of bias that e-cigarettes with nicotine increase quit rates compared to behavioral support alone or no support. Next. Issues with these studies in terms of sometimes there not being very many studies, sometimes risk of bias, preclude making strong conclusions about other comparisons, particularly around adding nicotine e-cigarettes to nicotine replacement therapy. But the data suggests a possible benefit there. So if you give everyone nicotine replacement therapy and then you give one arm nicotine e-cigarettes as well, it does seem that more people might quit smoking. So we want to see more research on that. And none of our included studies detected any serious adverse events that the study team thought were possibly related to e-cigarette use. However, some big caveats around this. These studies were kind of short to midterm, maximum length was 2 years. And these are not studies that are necessarily testing the e-cigarettes that people are going out and buying and using. These are studies that are testing e-cigarettes with nicotine that have gone through, previous slide, some quality control processes in order to be used in a study. So when we talk about these data, and especially if we're talking to people who smoke, who are considering using e-cigarettes, we try and really emphasize the need to buy an e-cigarette from a retailer that they trust, and make sure that essentially they're not tampering with it, because we know that a lot of the safety issues we associate with e-cigarettes come with things that are not regulated, that might be kind of made in the black market, and there you can end up with really serious side effects. As I mentioned, the most commonly reported adverse effects were things like throat and mouth irritation, headache, cough, and nausea, and these tended to dissipate as people got more used to using the e-cigarettes. I didn't have time to talk about the biomarkers today, but I'd really encourage you to go kind of look at our review, and I'm happy to take questions about it. But overall, what our data showed when we looked at measures of potential risk or harm was that these tended to be lower than in people who continued smoking. So if you gave someone an e-cigarette and they managed to stop smoking and keep using that e-cigarette, then what you saw was things that measure risk, they all went down. So that's a really positive finding in terms of what this suggests. And another concern in this space is that if you give people who smoke e-cigarettes, if they don't stop smoking, what happens if they are now smoking and vaping? And we didn't find any evidence that that would increase harm, and potentially some evidence that it might reduce it. Next slide, please. In terms of implications for research, we still need a lot more data in this area. We need studies which look at quit rates at 6 months or longer, compare e-cigarettes to active interventions that are already available to people who want to quit smoking, assess safety for as long as possible, and be powered to detect differences in safety outcomes. Think about safety both in terms of absolute risks of this product and how it compares to smoking tobacco. Ideally, offering devices to participants that are recent and good at delivering nicotine. We know this is hard to do just because of the time lag with conducting studies. Tell us things about the participants' use of the e-cigarettes, including flavors and nicotine strengths. And where possible, provide e-cigarettes in a way that kind of mimics what might happen in the real world, because we know most people using e-cigarettes aren't people who are part of these trials that are kind of heavily controlled and supported. Next slide, please. So for further information on our review, sorry, go ahead. You can move to the next one. For further information on our review, I've put up some things on the end of these slides. I'm really happy to share them, so you can just throw these up here. We have briefing documents. Next, we have a podcast where we talk about the evidence on e-cigarettes. Next, please. Next. And you can see our full review next for more detail on everything that I've presented today, data on some of our other outcomes, comparisons, data from our uncontrolled studies, and comparison with other reviews. Next slide, please. There's the link where you can find all of that information. And thank you so much. I'm really happy to take questions. I also know that that's a lot of information in a short amount of time. And if anyone wants to follow up with me via email after, they are more than welcome to.
Thank you. Thank you so much, dear Dr. Jamie Hartman Boyce. If you have any questions and comments, please feel free to use the chat box. I'm sure that your expertise with a powerful, well-methoded roof view and your vision and dedication were key to the success of this symposium event. In terms of understanding the studies in e-cigarettes for smoking cessation recently, I appreciate for that. So we are gaining many time to understand better and better, thanks to you and to your background, of course. I think after today also, Cochrane has become more interesting for all our participants who are here. I'm looking forward. I'm looking forward to listen to your podcast also. So it will be really exciting thing to see and to access to the link. Thank you so much for sharing. And you talked about many things, many highlightings about nicotine e-cigarette versus NRT and early adverse effects. And thank you for your outstanding efforts and sharing your knowledge with us at our evenings, at your morning. Thank you. Thank you so much.
My pleasure.
Thank you. So we are moving to our next guest speaker, dear Associate Professor Dr. Umut Kırlı. Now I'd like to introduce Umut Kırlı, who is one of my colleagues at Ege University Institute on Drug Abuse, Toxicology and Pharmaceutical Science in Turkey. Dear Kırlı is psychiatrist and psychotherapist focusing on abnormal psychology, psychiatry, addiction, and epidemiology. Today, he will talk about emerging trends in addiction. Please take the floor, dear Umut.
Thank you, Ince, for this nice presentation. I'm going to move on with my slides. I guess I will do it. Can you see it?
Yes.
Okay.
Yes.
Okay. I'm going to talk about emerging trends in addiction, mostly on the situation on Turkey and also in Europe. But I'm going to start with a very traditional quotation from Epicure, who is a Stoa philosopher from the first age. And he says that we follow pleasure and we avoid pain. And since birth that happens, and some pleasure turns into pain. And all the story of addiction is, I guess, is this. Now, there is a drug crisis also in Turkey. 36,000 people was delinquent 7 years ago due to crimes related to substances in Turkey. But now, after 7 years, the number came up to 128,000 people. It's about like four multiplications, and 1/3 of whole delinquent individuals are due to crimes related to substances now in Turkey. It's a huge number. As we all know, cannabis is the most used substance all over the world, followed by opioids and stimulants. It doesn't work. Yes. Let's start with cannabis, with the novel cannabis. Traditional cannabis had 2 or 4% of delta 9 THC. However, the cannabis on current market has about 25% of THC. So psychosis and other complications related to cannabis are also increasing, and we see this in this data. This study is from EUGI project, which is which is conducted in very important cities of Europe, including London, Cambridge, Amsterdam, and so on. As you see, in a city, if cannabis is used more frequently, then first episode psychosis is also very frequent. And these graphs also follow each other. Additionally, if people use cannabis with high potency, this association is more valid, as you see. And in a study in Izmir, Turkey, we conducted, I guess, 6 years ago, 1/4 of all first episode psychosis patients would never emerge if no one smoked cannabis. It's a huge number. So cannabis is still one of the most important modifiable risk factors for psychosis. We can modify it. We cannot modify genetics, but we can modify cannabis. However, in 24 EU countries, prevalence of cannabis use is increasing. It's about 17% now, and emergency service applications and treatment seeking also increases related to cannabis. If we move on to synthetic cannabinoids, a new version is emerging these days. It's called in black market A4. It's basically the paper. The synthetic cannabinoids are impregnated into paper, and they're sold in book pages, so it's hard to detect now. Another emerging trend is delta 8 THC. It's an emerging cannabis extract. So our analysis can capture delta 9 THC, but delta 8 THC is hard to detect. They are mostly vaped and sometimes eaten. So it could be a hard thing, and it's going more frequent and frequent in any days. If we move on to cocaine, we can say that there is a cocaine crisis in Europe because cocaine is traditionally frequent or prevalent in America. However, in these days, it's getting more frequent and more frequent in Europe, as you see in this graph from for the last 7 or 8 years. And in this graph, it's the metabolites from wastewater analysis in selected European cities. And as you see, in most of the European cities, cocaine is increasing. And as we all know, there's a methamphetamine crisis now. And as you see, the graph is moving, rising up and up in Istanbul. It's the data of EMCDDA. And it's one of the top causes of substance-related deaths together with opioids. And as you see in this map, methamphetamine metabolites increase in most of the European cities. Just a few cities are green, but most of the one are red, meaning increasing methamphetamine metabolites in wastewater analysis. And what is really interesting for me is we have 2 cities which are among the top 20 cities in Europe increasing daily methamphetamine. One of them is Istanbul and the other one is Adana. So and also in EMCDDA report, in the latest one, Belgium, Germany, Spain, and Turkey are the novel emerging countries for methamphetamine. So we also hear some methamphetamine laboratories in Istanbul. So methamphetamine crisis is an emerging trend in Turkey. If we move on to pregabalin, As you know, pregabalin is a medication for epilepsy, neuropathic pain, and generalized anxiety disorder. And in black market, you can find 300 milligrams, and it's about 100 Turkish liras per pill in black market. And typical abuse is about 1 blister, about means 14 caps in 1 blister. And when you basically search for pregabalin in Google, you can see some quotations like how is the intoxication of pregabalin? How do you feel when you abuse pregabalin? Something like that. So it's very prevalent. As Epicure said, pregabalin is something that makes you not to feel physical or mental pain by blocking voltage sensitive sodium and calcium channels. It's a alpha 2 delta ligand. So when you feel some pain in your soul, when you see some mental pain, these neurotransmitters cannot be released, so you do not feel, and you feel more euphoria. And it's also known in pre-marketing studies, number needed to trade is about 9. It's a huge number in pre-marketing studies also. And people use it for relaxation, and people use it for increased empathy and talkativeness. And after 2019, which is the date of restrictions for prescription in Turkey, prescription rate decreased by 50%. However, abuse rate increased. So now we can say that pregabalin abusers do not get prescriptions. They get it from the black market. If we move on to ketamine, as you know, ketamine is an analgesic and it's used for short-term anesthesia, but if you reduce the dose for 15 to 20%, you feel euphoria. And it's sometimes used for sexual assaults. And as you see in the map also, in most of the Europe, ketamine use or ketamine abuse is increasing. And this is an interesting report from the EMCDDA reports. It's the change by weekdays to weekends. And wastewater analysis showed that MDMA and ketamine increases at weekends. However, methamphetamine and cannabis is still stable throughout the week. So it doesn't change or it doesn't increase in weekends. And if we move on to synthetic catenols, due to EMCDDA report, record trades was observed in Europe in 2022, and all mephedrone is rising with the other synthetic catenols. What about the change in nicotine use in Europe? Smoking is decreasing. However, vaping is importantly increasing. So we should think about how to reduce vaping ratios about nicotine. And what about behavioral addictions? Is if we talk about gambling, cryptocurrency, and especially leverage cryptocurrencies are increasing, and also online, real-time, 3D and VR gambling is increasing. So the craving associated with gambling is also increasing. So as well as the leverage cryptocurrencies, which are totally legal. So I would like to thank you, and if you have any questions or concerns, I would like to answer.
Thank you so much, dear Umut. If you have any questions, please feel free, as always, to use the chat box. And also, we have students, PhD and master students here from maybe our students who would like to take the floor with microphone or writing, tapping. Please feel free. So thank you so much for your highlighting the issues on emerging trends and addiction. We should be aware of it, especially by the professionals who work in this field and also decision makers, right? You shared with us very valuable information about the new agenda, addictive substances, and emphasizes that we need to focus more on this issue, including gambling addiction and other technical issues, including technical and technological tools. And thank you so much for highlighting, for helping us to focus on more and more on this issue. And if you would like to share your comments and your if you have questions also, we have time for this. Thank you. Thank you so much.
Thank you very much for the invitation. And let's see tomorrow.
Tomorrow is another work day for us for focusing on what to do in this field, right? As clinician and as academician, also in national and international projects, you have very experience, and thank you so much for this opportunity to share your knowledge. And in terms of your background, until today you have collected. Thank you. Thank you so much.
Thank you very much.
Okay, so we are moving to have a short break until Hassan, how many minutes do we have? I think
I'm looking at it. I think we had a 15 minutes, around 15 minutes time.
15 minutes, right? Okay,
Yep.
so after 15 minutes, we will be here with our moderator, the second part, dear Hasan Serkan Taşkan, and he will be here with your participation, of course, and with our guest speakers from Romania, Austria, and also from maybe another organization, in another field from Greece. So you will be very, I think, satisfied in the field of what are the projects, what are the practitioners in the field in terms of preventing or interventions on addiction. So hopefully we will have a break and we will go on at this evening. And if you are listening to us from another part of the world, so please be here. And you would like to say anything, Hassan, for the second part?
Actually, I want to thank you for your moderation.
Thank you. You're welcome. You're welcome. Thank you so much for your
See you in the second part.
See you. See you. What is the exact time for Turkey time and for CET time? Maybe you can tap it on the chat box, and everybody is following the process. Thank you. See you again.
I'm Hasan. I'll moderate the second part of the symposium. Before we start, I again want to thank all of the speakers and especially the moderator, lecturer Inci Derya. It was really mind-opening first session for me. Let me introduce myself shortly first. I'm Hasan Serkan Taşkan. I'm a psychologist. I did my master's degree on drug addiction in Ege University, and also doing my PhD on drug addiction. I'm working with Professor Yarabaş. My studies focused on tobacco use disorder. That's it for me. Maybe we can start. Our first speaker in the second part is Dr. Antonella Cristina Tearok. She is a professional social worker and university lecturer at the University of Bucharest. She will talk about the therapeutic community method for the treatment of drug use and its results in the Bucharest-Ilava Penitentiary.
So, first of all, I am a social worker, and I work since 1996 in Bucharest Jilava Penitentiary, nearby Bucharest, of course. So I have almost 28 years work in this field, and with drug users and with inmates. This penitentiary now is a penitentiary with open and semi-open regime, but for many years it was with maximum security regime. In 2009 and 2011, me and several colleagues from penitentiaries, probation services, and National Anti-Drug Agency, we were specialized in an interesting method of treatment of former drug users, and it's about therapeutic community program. This program involves a non-drug intervention, no pills, without methadone substitute or syringe exchange. It is about only psychological counseling, and especially in group. Everything is shared among the residents of the program, these residents are separated from the others, both in terms of accommodation and activities. Activities involve work, school, professional qualification courses or vocational courses, and, as I said, a lot of group counseling. One of the basic principles is that each of us can learn from each other's experiences, and if we know what problems you have as a resident, we can help you as a group. Right from entering the program, newcomers receive a big brother who teaches them everything they need to know about the program's routine and rules. So every resident of the program has a big brother. Every moment of the day is occupied, is busy, they are very busy with various activities, this being one of the keys to the success of the program. So now this was a few words about the program, and now I want to share my slides, please, if it's possible, the second one. In April 2011, we started this program with Norway funds, and our mentor was a therapeutic community from Norway, Phoenix Haga. And we started with 24 beds in 3 rooms in the penitentiary, of course, separate wing, with 2 residents, 2 inmates, former drug users, and a multidisciplinary team, 2 psychologists, social worker, an educator, and of course, with a new mentality and new methods. So nobody believed us, or nobody believed in us. The staff and the other inmates were very ironic with us because they consider it as we are naive to believe that someone can change their behavior without pills or, I don't know, methadone as a substitute. Please, next slide. Just few words about the inclusion criteria. Of course, we have this program with former drug users. They should be abstinent. So we test them before to entry in the program. Should have they are not with sorry. They don't have violent crimes, no psychiatric treatment, and should have good behavior in general speaking. Here in Romania, we have parole commission. So every resident should have between 12 and 24 months to the parole commission and to be in open and semi-open regime, of course. Next slide, please. So when we began this program, we had, like I said, 24 beds, but now we have 40 beds. We have a long waiting list, because a lot of inmates, after more than 10 years, 12 years, many inmates from our penitentiary and from the country asked to be resident in this program. So now we have 39 residents, and if from the beginning they didn't work outside the penitentiary, now, as you can see, 31 are working outside the penitentiary, and 5 of them without supervision. They are free to go and to come every day to the penitentiary.
Yes.
Just to give some explains. So I want to highlight that if in the beginning nobody trusts us and they thought we are naive to think an inmate can change his behavior only with, I don't know, psychological counseling, it's very important that now everyone respects the residents and, of course, the staff, and they have authority in the penitentiary. Every staff want to work with these residents, and this program has a spirit, very good spirit, and a lot of multidisciplinary teams from the penitentiaries adopted this our TC, or therapeutic community spirit. So we were pioneers 12 years ago, and now we are models in our penitentiary and in our prison system. It's okay now with your slides?
Now, I'm in the where are we now slide, but I don't know the participants' view. Maybe I can move to this slide which you would like to.
6.
Next. This
Six.
one? 6th.
Yeah.
So this
With,
one?
on October.
Yes. Thank you.
Yeah, it's okay now. The next, I think, on October 20.
Now it's on October, but before maybe it will take time
Okay,
to be experienced at your side.
no problem,
Please,
because I
please
can
go.
tell you
Okay.
that now, after 12 years, we had analyzed, of course, our data. And through the program were 511 inmates included so far, and almost 38% graduated this program. Of course, a lot of them, 21%, drop it out of the program, especially because they did not adapt. If you remember, I told you that this program supposed to give a lot of trouble to the residents. I mean, they are very busy all the time. They should work, they must work, and go to school. So not everybody adapt to this program. What I want to try to say you, it's very important to know that the recidivism rate in Romania is now 38%. But analyze the data from our therapeutic community in these 12 years of existence. The recidivism rate is 21.57%. So it's lower than national recidivism rate in our country. Another slide, please.
I clicked the next slide.
Okay, so the 7th about behavior.
Dear Tarok, our time is almost up, so I would appreciate it if we could wrap up.
Okay, so just 3 minutes. I want to share you that this program improved a lot. I have conclusions almost done. Yes. Please help me with the last slide. Why this TC is a good program? Because change a lot their image. From a negative image, every inmate said, "I have no value." Now they are useful, and they have transformation image. Building an island, because this program is like an island in our penitentiary. Everybody wants to come there, and even they don't, all of them resist. They want to try another kind of life. And of course, the last but not the least, the democratization of relations between staff and residents, because we transfer responsibilities to the inmates and helps the residents, the inmates, not only to work, to learn a work ethic work, but also to be democratic, independent, and to have a healthy behavior in all their aspects of life. Thank you.
I really thank you for your speaking, dear Dr. Tarok. Even though we have some technical issues, it was really good to listen to you.
Sorry for this.
I guess we are all accustomed to these type of technical issues because of COVID. Again, it was nice to meet you. Is there any question about maybe therapeutic communities? I guess we don't have right now.
Thank you very much for your invitation.
Thank you, dear Tarok. Now we will continue with the lecturer Saskia Erhardt. She has many years of professional experience as a social therapist and social worker in the addiction support area. She deals primarily with the social dimension of health and illness. Her talk will be on the pathogenic potential of consumption and social media. Now the floor is yours, dear Erhard.
Hello, can you hear me? So I'm afraid.
Hello.
Hello, can you hear me?
Yes, we can hear you.
I'm afraid I cannot share my camera, but I tried to share my slides.
So we can see you right now.
Okay.
Okay.
Okay. So I
We are seeing you.
wasn't sure about that. So fine, great. Okay. And you can see my slides too?
Yeah, no problem at all.
Great. Okay. So thank you for the welcome and the invitation to your symposium. I'd like to invite you to follow me over the next 15 minutes when I share my point of view on consumption and its pathogenic potential. The following presentation is about consumption and consumer behavior. Digital products and services are the issue of interest. It is common sense that digitalization products are highly functional and useful for lots of people. Our actual video call is an example for that. However, I would also like to show another side of the consumption of digital products and services. Due to their commercial orientation and design characteristics, they have a pathogenic potential. My observations are made from the perspective of clinical social work and therefore focus primarily on the understanding of consumption and the effects of our consumer behavior on our social participation. I will first define the term consumption, then go into digital products and services, especially social media, and show the pathogenic potential. Finally, I will make a suggestion as to how this problem could be dealt with from the perspective of clinical social work. So firstly, the understanding of consumption is, like Viswede wrote in the year 2000, presented as a comprehensive process that encompasses various phases, from the emergence of a need through to several steps you see here in that circle, until the reflection on future needs at the end of the circle, where the process starts again. The model shows an idealized process. I think in reality, not every phase has to be completed. There may be interruptions and parallel consumption processes. I would like to emphasize the close link between consumption and lifestyle, which extends across all phases of the consumption process. If you look at the several phases, so please be invited to ask yourself, where do your needs come from? What inspires you? Who or what has an influence on your decisions, your needs, advertising, influences, recommendations? In fact, the digital world offers plenty of individualized opportunities to address our needs and trigger our consumer behavior. In the next step, let's look at user behavior while consuming digital products and services. Digital products and services are specifically designed to influence user behavior. Business models are designed for intensive and regular use and aim to maximize the time we spend on platforms and to collect usage data. The design of many products triggers the reward system and creates emotional involvement and habits. Think, for example, of like buttons, click rates, number of followers, surprising effects, and many other features which are designed to attract our attention and to involve us in an emotional way. A key aspect concerns to the use of social media. Please first look on the left side of the slide. Statistics show that large proportion of the German population, so 57%, actively use social networks, with young people in particular becoming more involved. Actively means they create and share content. Young people use more different types of social media, up to 7, than older persons. Social media is primarily used to obtain information, form opinions, and have social exchange. Now, please look on the right side of the slide. Nevertheless, the number of victims of hate speech and media usage disorder is increasing. Studies indicate that excessive use of social media is associated with a deterioration in mental health, particularly among girls. The frequency, that means how often per day social media is used, is here essential. Girls who use social media only once a day have a significant lower risk of performing worse in terms of their mental health. Mediators which were identified are less exercise, poor or less sleep, and getting in contact with cyberbullying. Peer groups are also shown to influence usage behavior, especially the age when persons start to use social media, and the functionality are influenced by peer groups. The information outlined above clearly shows that the need to strengthen preventative interventions and implement new approaches in education and family policy in order to support children and young people in the responsible use of digital products and services like social media. One suggestion is the use of mental health coaches in schools. This theoretical model by Müller et al. Illustrates the potential impact of the consumption of digital products and services on both online and offline well-being. The original model is in German, but for today's topic, only the left side is important, which I translated in English. So please have a look on the left side of the slide where you see the red arrow. First, there is an interested usage behavior and an increasing online well-being. An increase in the duration and frequency of online use can lead to a decrease in offline well-being. Dissatisfaction of various needs is shifted into the virtual space. If needs are not satisfied here in the virtual space, or if they are frustrated, this can lead to more online efforts to satisfy needs. That means we find an increase in online usage behavior. The resulting excessive online use can escalate into addictive online usage behavior, which is then accompanied by a decline in both online and offline well-being. This can have serious consequences for the development of social participation, particularly in the age range of the heaviest user. Remember, these were the 16 to 29-year-olds. The consequences affect two important tasks of development in that age: school and apprenticeship qualifications, vocational education, and integration into social systems can be impaired by addictive usage of digital products and services. So let me summarize the most important points at the end. Digital products and services are not only objects of consumption themselves, but also they are also platforms for other consumption processes. They have a double use in the consumption process. Their business model is aimed at intensive use, while the product design is aimed at strong user loyalty. This combination of business interests and the intertwining of consumption and lifestyle entail potentially pathogenic aspects. It is therefore important that we take the specific design of digital products and services into account when we use explanatory models for usage disorders, just as we take into account which substances are consumed by people. Only then can preventive interventions work properly. It is crucial to educate users about functional usage behavior and risks at an early stage, to set up specialized advisory centers, and to develop and implement ethical programming guidelines. I hope I've been able to illustrate my point of view. Now I look forward to your questions. Thank you very much.
I really thank you for your presentation, dear Rahad. The social media and its potential pathogenic consumption is really an interesting and updated topic. Is there any question from the audience on it? I think we don't have any questions for now. Again, I really thank you to be here. I hope we can work and collaborate in the future again. Nice to meet you.
Yes, thank you very much.
Now we will move on. The moderator of the first part and speaker of the second part, the lecturer İnci Derya. She is a PhD candidate on addiction with a thesis on tobacco use. She is also a psychologist with solution-focused therapist and certified mindfulness trainer. Her topic is psychological factors in smoking cessation clinic, analysis of adherence, depression, and anxiety.
Thank you so much, Hassan, for this introduction, great introduction. And I'm sharing my screen. If it doesn't work, let me know, please, and we can find another solution, maybe. Do you see my presentation?
I can see it right now.
If it doesn't change, let me know again, please.
Okay. Can you try to change it?
I changed.
Okay. It changes.
Okay. Esteemed colleagues, participants, and honored guests, good morning, good afternoon, good evening, everyone, wherever you are right now. I'm delighted to be here today to discuss a topic that not only impacts about public health profound, but also delves into the intricate web of human behavior. My focus today is on psychological factors in smoking cessation clinic, analysis of adherence, depression, and anxiety. Our title is our study's title is investigating of the patient's adherence, depression, and anxiety levels in a smoking cessation clinic, where we work together with Görkem Yararbaş. We put a method, we include a method in a study, in a cross-sectional study. And I would like to very briefly to share with you these cross-sectional findings we obtained during our work at the smoking cessation clinic with the patient. Smoking continues to be a substantial issue for public health worldwide, as you know, linked to the premature deaths and various illnesses. And although researchers have extensively examined the physical components of nicotine addiction, the part that psychological factors play in the smoking cessation process is a progressive area requiring attention by the patient. Smoking cessation clinics are very crucial in aiding those who strive to break free from tobacco addiction, tobacco use behavior. Today, I will talk about very briefly aiming to examine three essential psychological dimensions, which are adherence, depression, and anxiety, and their interconnections, connectedness. I think that whether an individual may move towards a smoke-free life is significantly hinged on these dimensions. Without delay, let us examine the psychology factors involved in smoking cessation clinics. The aim of this study was to investigate relationships between tobacco addiction level, depressive level, depression level, anxiety level, and mental health well-being level of adult male and female individuals who use tobacco and who applied to our smoking cessation clinic at the institute. Our primary outcomes were increasing patients' levels of depression is an effective means of increasing the level of tobacco dependence, and increasing the levels of generalized anxiety in patients is effective in increasing the level of tobacco dependence. And as a secondary outcomes, patients' levels of mental well-being increase the level of tobacco dependence. Our research design is that this cross-section study aimed to investigate the level of patients' adherence, depression, and anxiety within a smoking cessation clinic. The sample of study, this study consists of 32 male and female participants over the age of 18. And between the January 2023 and until November 2023, and requested psychotherapy support for smoking addiction and met the inclusion criteria. The patients who presented to clinic and met the inclusion criteria, exclusion criteria were consecutively enrolled, and no randomization process was applied, and the participants were selected in a linear fashion. Here are inclusion criteria and what we used, the forms and scales names. A short questionnaire was used with 3 items about adherence to the treatment, and the scales, the Fagerström test for nicotine dependence, the patient health questionnaire 9, generalized anxiety disorder 7 with 7 items, the Warwick-Edinburgh mental well-being scale, the 7 items, with the 7 items, and also you will see what kind of questions were asked during the questionnaire. And when the socio-demographic characteristics of these participants were examined in general, it was seen that they were over middle age, most of them were women, their education level was generally high school graduate, they were generally unemployed and married. In addition, the average past smoking period is 18 years, and the average number of cigarettes consumed per day is 24. 75% of the participants had attempted to quit smoking at least once before. Table 2 shows the results of the multiple linear regression analysis very briefly, which were adjusted for all variables identified to be associated with addiction level. According to the regression analysis, depression level and anxiety level were explanatory of tobacco addiction level. Of course, this small group is very unique group because they expected to have a psychotherapy from a smoking cessation clinic in addition to medical advice and using medical. So these are very expected results when we think the target of this study, and generally the correlations are very high when we think about it. These psychological factors, parameters, and PTND, I mean nicotine dependence, or using nicotine levels. Seen in this table, there was a significant difference between the anxiety and depression levels of the patients in terms of PTND scores, I mean tobacco addiction. In addition, a high correlation was found between mental well-being scores and PTND scores. As can be seen in this figure, individuals with high tobacco addiction have lower levels of mental well-being, more depressive symptoms, and higher anxiety levels. In this figure, 71.88% of the participants stated that They had sufficient information about the treatment recommended, explained to them by their doctor. The rest of them stated that they realized they needed more information after the interview. So sometimes after the interview with the doctor, they feel that they need more information about the treatment or anything, because sometimes it can be their first experience to talk about their smoking cessation, their smoking cessation plans, etc. So at the beginning they can be shy, or they can introverts, or any other parameters can be role during this process. 46.88% of the persons stated that they believed that the treatment recommended to them would be useful in quitting smoking. However, 21.88% of the persons stated that it would not be useful at the beginning of the treatment process. So 59.38% of them stated that they made a plan in their own lives in addition to using medication during the smoking cessation process, which is really, really important for us to understand their motivation to their process in 1 week and in 1 month, maybe in 3 months. And in other words, she has concrete plans to make it easier for her to quit smoking. As conclusion, according to the findings obtained in this study, psychological parameters, as I said, anxiety, depressive symptoms, and general mental well-being are highly associated with tobacco dependence, tobacco addiction among patients who come to the clinic and expect psychotherapy from us. In future studies, patients in this group who are expecting psychotherapy should be compared with different groups as recommendation. What are the limitations? Number of departments is very, very quite small. We expect that more participants, more patients will give us more information about this group. There was no standard period between the day of the person's first treatment examination by the doctor and the day that they came to me for psychotherapy within the scope of this research. So it's a mediator variable in this study. Persons may have been maybe hesitant to give accurate information to an expert they contact for the first time. So here are my references, and thanks so much. If you have any question, I'm ready to answer.
Thank you for your presentation, dear Inci. Actually, it was really good to listen the adherence perspective of smoking, in addition to depression and anxiety. Is there any question from the audience? I'm checking the chat box. I guess we don't have it right now.
Thank you so much.
Now we will. Thank you. Now we will continue with Dr. Demet Havaçeli Atlam. She is a sociologist who works in the areas of health sciences, youth studies, addiction sociology, stigma and attitude, and her presentation will be about the stigma too. Her presentation is titled Stigma and Addiction Focus on Society. Now the stage is yours.
Thank you very much, Hassan. I will share my presentation with you.
Okay.
Is it okay?
I can't see it yet. Maybe the connection might be slow.
Okay.
It's coming, I guess.
Okay. My subject is on stigma and addiction, especially I will focus on society. We can see the stigma from the ancient Greece, and it was first used in ancient Greece to leave a permanent mark on the slaves and criminals' bodies with a pricking method or cauterization. And this mark has a very big meaning because of the meaning of worthless, bad people or immoral. And similar method was used to the criminals in the Middle Ages as well. In the Middle Ages, we can see the society thought that people with mental illnesses were punished by gods because of their illness, and they were under the influence of demonic spirits. So today we can say it's hard to solve this problem because of that kind of thoughts. Stigma of mental illness, we can see throughout history, chronic illnesses, mental illnesses, and infectious illnesses have been stigmatized. And today, we can see the stigma is very deep-rooted. Today, 80% of psychiatric patients are exposed to discrimination. What is stigma? And the Gottman stigma theory is very important for us because it's the first theory on this theme. And we can see, and the stigma is a kind of symbol of admissibility, and this symbol distinguishes the people normal or abnormal. And Gottman stated that and the stigma was directed toward physical disabilities, personality traits, especially the alcoholic and addicts people or criminal people or mentally ill, and ethnical and ethnological traits like a kind of race, religion, or color and class differences. When we look at the components of stigma, we can see the first component is stereotype. It's a kind of negative thoughts about the people, and this kind of beliefs and qualities suddenly become in our mind because of our cultural elements. When I say it's an alcoholic person, we can think similar things about because it's so deep-rooted because of the cultural elements. And we can see the stereotypes such as dangerous, unexpected behavior or weak-willed. When we look at the prejudice, it's a kind of combination with thought and feelings, and we can see negative emotions, so fear, anger, and disgust. And people can internalize the prejudice toward a stigmatized group, perceive it as their personal preference, and it's hard to distinguish, is it my opinion or the society opinion, because of the prejudice is very so deep-rooted. And the other components is on discrimination, and discrimination is a kind of behavior, and this behavior is, for example, avoidance and not providing employment and housing, and not helping, social exclusion and separation. When we look at the stigma presence, we can see the structural stigmas. The structural stigma is a kind of social system, so we can see it some elements. It's our social structure. Government, media, religion, health, education, and law. So these kind of elements determine the policies, norms, and list of procedures. And so the other stigma, it's a kind of social stigma or public stigma, and we can see the society determines the criteria and the values that can be normal or abnormal, and society decided that kind of values according to their culture and norms. So the last process of the stigma, self-stigma, this is important for us because we can see that kind of stigma, and we have to solve this problem for the circle of addiction. So the self-stigma, it's people with SUDs, people with substance use disorder, and perceive the structural and public stigma, and they can accept the levels like dangerousness or worthless, and they can feel hopeless, shame, anger, sadness, and fearness. So they prefer to avoid public area. They prefer not to contact with the society, and they prefer to isolate themselves. So we can see the self-stigma leads to social exclusion and social isolation and loss of social status. So the self-stigma is caused to stay in a circle of addiction and social isolation and avoid treatment. So it's very important for us. When we focus on the society, we can see the social construction, and governments say that it's a kind of social construction because when we think about a person, he or she can be an intelligent, helpful, successful, have a good job, and maybe a profession and student. But after an addiction problem, we can think and the society gives a new identity. That identity is only you're addict, you're alcohol addict, you are a user, something like that. So it's a kind of cultural transfer. And any social identity has been constructed by the society. So it's a kind of social construction. When we look at the stigma of substance disorder, is the first rank in the world. And because of the terminology, because of the insulting language and relationship with crime, and the society thinks that it's a personal choice and it's a kind of moral situation. It's not a disease. And we can, because of the effects of the drugs and the alcohols, it's a kind of unexpected behaviors or aggression or strange behaviors. When we look at the language, we can see that that kind of words. The society says that alcoholic, user, abuser, drug addict, a junkie or addicted, and this kind of words are so stigmatizing. And even the definition of toxicological test results, dirty, increases the stigma. For example, a forensic case or a patient can ask to the clinician, how is my toxicology test? Am I dirty or clean? So that kind of word is very stigmatizing. So if we want to change, if we want to reduce the stigma, we should begin to change our language and terminology. Even the addiction and even the dependence, something implies that the SUD and the AUD always have the same behavior and change is impossible. When we look at the relationship with crime, we have known drug use is the risk factor for criminal behavior, especially violence behavior and theft. And the existence of different evaluations within the justice system and the evaluation of substance use is a crime, affect the stigma. In Turkey, and drug use is a crime, cannabis use is a crime. So the Turkish people think more severely than the other countries about this subject. And the society thinks it's a personal choice. Alcohol use and substance use is a personal choice. So they blame the people because of our preference. And so society consider and alcohol use and the substance use the moral situation and not a disease or a behavior problem. And morals of people are questioned, and it is thought that they are weak fields and they have a criminal tendency. When we look at the determinants for social stigma, especially the drug use. The place where the substance use is important because it's at home or at streets. And the type of drugs is alcohol or illegal drug, or it's cannabis or heroin or crack. And the type of methods, it's inhalation method or injection method, and the behaviors under the influence. It's a kind of violent behavior. It's something social cues about that, and character traits or infectious diseases and the other mental illnesses, comorbid illnesses, and the gender. Gender is very important, and we can see the women are more stigmatized because of the motherhood and the pregnancy period, and the crime. Race, ethnicity, and the color, we can see the double stigma, and belonging to any social group and social status or profession are some determinants for the society. When we look at the women's stigma, we can see that the society focuses on women's gender roles and moral values. And so they think that a woman cannot be a good wife and the family unity will be destroyed. And for this reason, women are labeled as irresponsible or morally weak. And this is my last part. And is it possible to change social stigma? How we can do this? And we should tell the origin of addiction and biological factors about the disease to the society. And we should begin to change the source of stigma. And this source is stereotypes. This source are thoughts. And we should give the scientific and real results about addiction to beat this stigma. And we can try to improve the empathy for the society, and we can contact with society and drug use people with drug use disorder, and we can try to interact with them. So we can have a possibility to change the misinformation. Okay, thank you very much for listening to me.
Thank you, Dr. Atla. I would like to thank you for your contribution as a sociologist from a different perspective. I think we all need to pay particular attention to stereotyping, prejudice, and discrimination in total of stigma when working with addiction. It was really valuable for me, and I'm sure for our audience too. Is there any question about the presentation? I guess we don't have any question again.
Okay.
Everyone is exhausted. Now we will again thank you, Doctor.
Thank you very much, Hassan.
Now we will continue with our last speaker, Theodoros Kostoulas. After Mr. Kostoulas' presentation, we'll have a closing speech and finish the symposium. Let me introduce Mr. Kostoulas before his presentation. He's a mechanical engineer with years of experience in program management, educational programs development, and project coordination. He will talk about the social reintegration of substance users. His presentation's title is You Have a Second Chance, Vocational Training and Social Reintegration for Former Substance Users. The stage is yours, Mr. Kostoulas.
Hello, everybody. Hello.
Hello.
Hi, I want to thank you again very much for the invitation. I want to congratulate all the speakers that came before me for this amazing information and insights. I'm going to start by sharing my presentation. Please tell me if you can see my slides changing.
Yes, I can see your slide changing.
Perfect. So my name is Theodoris. I'm here representing a non-profit organization from Greece called Odyssey, which supports vulnerable people's integration into society by offering vocational training courses and employability services. Also, a big part of our work is relief programs, which is the umbrella under which is the program that I'm gonna tell you about today. So the program You Have a Second Chance is a program that has been co-designed by Odyssey and another organization from Greece called Kethia and Rasi. The program started because the situation in Greece for former users of psychoactive substances is very severe. For them that have been held into detention facilities, 77% of them end up returning back to prison. Less than 30% of them end up in stable employment, and less than 9% of them have been through post-secondary education. So we decided to act on that. And how we do that, we designed a program with a holistic approach that combines therapeutical support, skills development, and social integration through employment. A few words about Kethia and Rasi, our partner. Kethia and Rasi is a welcoming center that tends to the rehabilitation of former substance users who have been in prison, and it's been going for a long time and really doing a wonderful job. I believe you should definitely check them out. A few words about the program. Program is designed to have 3 phases. The first phase takes place within the detention centers, where Kethia and Rasi has a special wing within the detention centers where they support prisoners with, of course, the attention of social workers, psychologists that offer support to the people. What Odyssey does is we go within the detention centers and offer a series of courses that include, of course, soft skills development, digital skills development, and also and foremost, vocational training courses. I mean, this year we did cooking courses, woodworking courses, and also jewelry creating courses. The second phase starts immediately after someone gets released from the detention center, where they continue to receive therapeutic and post-therapeutic support from Kethia and Rasi, and also continue their skills development in Odyssey's premises, where they go deeper into the content of the vocational training they have chosen. And the third phase concludes the post-treatment supervision, which concludes the offerings of the projects, where if we are fortunate enough, the participants of the program have been connected with the job market, with job positions that fit their personality, their skills, and their aspirations. And of course, they still need support, they still need psychological support, and they still need in-work support, which Odyssey offers by constantly staying in communication with them and their employers to ease their integration into the professional environment and assist their career development. Program started in 2023 in two of the biggest detention centers, facilities in Greece, and actually in Athens and near Athens, the biggest of them being Korydallos. And we're fortunate enough to renew our funding sources to continue this program, and not only continue it in 2024, but also add more facilities in the program, 3 more, as you see the ones in red color. And we get the chance to expand it a little bit further than the borders of the city of Athens. The program's impact to the participants and to, of course, to society as a whole is of great significance, in my humble opinion. There were a lot of people participating within the detention facilities, both in soft skills development courses and vocational training courses, but also outside the center. And what's really worth mentioning here is that we managed to secure employment for 40 participants, and this number is, of course, constantly growing as we go. It's not something that ends when the calendar year ends. What I really want to say here, though, is that if you consider the statistics that I showed you at first, 77% of the people returning, unfortunately, to prison. We have a very heartwarming statistic within the program, and it's that 60% of the people that actually finish the program managed to find employment and see their future lives with hope and find another path that would lead them away from what troubled them before. And what's also really worth mentioning is that Odyssey overall has about 2,000 people participating in the programs, and the people from this particular program are actually the best case scenarios. We get feedback from their employers that's very encouraging and helps us moving. And I've listened carefully to what all the previous speakers said before. We've taken that into consideration, and I really hope that in each country, programs like that offer some viable options and sustainable options for the next step, for what comes next, for a second chance into society. I know that this has taken a long time. Thank you all for your participation. I don't want to take any more of your time. I am, of course, willing to answer questions if you have them.
Thank you, Mr. Kostulas. You ended the symposium very well by talking about vocational training and social reintegration of substance users and its societal impact, actually. Is there any question about the presentation? Maybe. I guess we don't have it right now again. Thank you for being here.
Thank you.
It was nice to meet you.
You too.
This was our last presentation before. Oh, we have a question. If Mr. Kostulas didn't leave yet.
No, I'm here, of course.
Duygu Altın says, did you add new participants in phase 2 or were they the ones in phase 1?
One more, please, once more.
Did you add new participants in phase 2 or were they the ones in phase 1?
Yes, well, when the program started, there were people within the detention centers and also people outside during the rehabilitation process. So all of them started at once. So it's not an actual linear process, but a lot of them that were inside the detention centers and happened to be released within like 1 or 2 or 3 months since the program started, they were of course welcome to the other phases. But most of the participants of phase 2 were people that had already been released a few months before.
I guess, is it okay for you, Duygu? It was really nice answer. Okay, she says thank you.
Perfect.
This was our last presentation before the closing speech. I want to thank all of you for coming and listening to the end of the symposium actually. And now I would like to invite the lecturer İnci Derya Yücel for closing remarks.
Thank you so much for this great moderation task, and also our guests and our host speakers at the second part of this evening event. And yes, it's time to send a very big thanks. Dear participants, esteemed speakers, as this event draws to a close, I would like to take a moment to thank to all of you. Above all, I want to extend my heartfelt thanks to our respected speakers. Thank you for enlightening us and sparking useful discussions that will shape our future, our professional future, maybe. I also want to acknowledge the hard work of the organizing group in our Department of Drug Abuse, dear Hasan and Demet. They were with me during the preparing this process. And also thank you so much for joining in this preparation process with our guest speakers also. Planning an event like this is challenging, and your dedication is admirable. I hope it was very beneficial for all participants today here who spent their time to join in as online with us. Thank you for taking part and contributing. I hope to see you again in another international event. Bye and take care.